to Empowering Nurses to Protect Themselves and Their Patients, a discussion of current infection prevention and control challenges in maternal and child health settings. The audio for today's conference will be coming through your computer speakers. Please ensure your speakers are turned on and the volume up. The next 4 slides will cover the continuing education information for today's webinar. CME, the Centers for Disease Control and Prevention, is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. The Centers for Disease Control and Prevention designates this live activity for a maximum of 1 AMA PRA Category 1 credit. Physicians should claim only the credit commensurate with the extent of their participation in this activity. CNE, the Centers for Disease Control and Prevention is accredited as a provider for continuing nursing education by the American Nurses Credentialing Centers Commission on Accreditation. This activity provides 1 contact hour. CEU, the Centers for Disease Control and Prevention is authorized by IACET to offer 0.1 CEUs for this program. CECH, sponsored by the Centers for Disease Control and Prevention, a designated provider of continuing education contact hours, CECH, in health education by the National Commission for Health Education Credentialing Incorporated. This program is designated for Certified Health Education Specialists and or Master Certified Health Education Specialists to receive up to 1 Category 1 continuing education contact hours. CDC provider number is 98614. For Certified Public Health Professionals, CPH, the Centers for Disease Control and Prevention is a pre-approved provider of Certified in Public Health CPH recertification credits and is authorized to offer 1 CPH recertification credits for this program. CDC is an approved provider of CPH recertification credits by the National Board of Public Health Examiners. Effective October 1st, 2013, the National Board of Public Health Examiners accepts continuing education units for CPH recertification credits from CDC. Please select CEU as your choice for continuing education when registering for a course on TCE online. Learners seeking CPH should use the guidelines provided by the NBPHE for calculating recertification credits. Please visit their website for assistance. In compliance with continuing education requirements, all presenters must disclose any financial or other associations with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters, as well as any use of unlabeled products or products under investigational use. CDC, our planners, our presenters, and their spouses or partners wish to disclose they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Planners have reviewed content to ensure there is no bias. Content will not include any discussion of an unlabeled use of a product or a product under investigational use. CDC did not accept commercial support for this continuing education activity. Nurses use their expertise and skills to help provide safe care and treatment to patients. Adherence to infection prevention and control recommendations is critical to prevent occupational exposures and the cross-transmission of pathogens in healthcare settings. This webinar will discuss infection prevention practices and challenges in women's health, obstetrics, and pediatrics, the importance of standard precautions, and practical solutions and ways to implement infection control in these specialty environments. The objectives of our Infection Control and Prevention webinar series include describing infection control techniques that reduce the risk and spread of healthcare-associated infections, or HAIs, identifying unsafe practices that place patients at risk for HAIs, describing best practices for infection control and prevention in daily practice in healthcare settings, and applying standards, guidelines, best practices, and established processes related to safe and effective medication use. In this specific webinar, We will examine standard precautions as they relate to patient safety and occupational exposure risk, present challenges and practical solutions to increase adherence to infection prevention and control practices in these specialties, introduce risk recognition and implications for practice in the pediatric, women's health, obstetric, and neonatal specialties, and discuss occupational exposure risks and considerations. Hello again, and welcome to today's webinar, Empowering Nurses to Protect Themselves and Their Patients, a discussion of current infection prevention and control challenges in maternal and child health settings. My name is Erica Tyndall, and I am a public health analyst and infection preventionist at the CDC's Division of Healthcare Quality Promotion. The mission of CDC's Division of Healthcare Quality Promotion is to protect patients, protect healthcare personnel, and promote safety, quality, and value in both national and international healthcare delivery systems. As mentioned, this webinar is part of a series of infection control-related webinars that CDC hosts with the American Nurses Association and members of the Nursing Infection Control Education Network. Before we get started, there are a few housekeeping items to cover. We welcome your questions. Please submit any questions or comments you have via your chat window located on the lower left-hand side of the webinar screen anytime during the presentation. Questions will be addressed after all presentations as time allows. To ask for help, please press the Raise Hand button located on the top left-hand side of the screen if you need to chat with the meeting chairperson for assistance during the webinar. Also, the speaker slides from today's presentation will be provided to participants in a follow-up email. As a reminder, today's webinar is being recorded, so please visit our Tune Into Safe Healthcare website in a few weeks for the recording. Before I pass it on to ANA, I would like to take a moment to introduce our speakers. Dr. Elizabeth Roshan is from the Association of Women's Health, Obstetrics, and Neonatal Nurses. Dr. Roshan is the Vice President of Nursing at AWAN. Dr. Roshan joined AWAN in 2016 and is responsible for advancing the areas of women's health, obstetric, and neonatal programs for the association. She has over 25 years of women's and children's experience and has devoted her professional career to the care of women and children and the nurses who care for them, with roles as a staff nurse, nursing educator, and health system executive. Dr. Beth Luthi is from the National Association of Pediatric Nurse Practitioners. Dr. Luthi is well known for her involvement in vaccination promotion activities. Since 2006, Dr. Luthi has authored many articles on the topic of immunizations. She has served as the chair of the Utah County Immunization Coalition and the chair of the Immunization Special Interest Group for the National Association of Pediatric Nurse Practitioners. Now I will turn it over to Dr. Sean Ross with ANA.
Thank you, Erica. My name is Dr. Sean Ross, and I'm the Director of Nursing Practice and Work Environment at the ANA. As the world becomes more global, the potential to spread infectious diseases across countries has increased. Outbreaks within the last decade have pushed healthcare organizations to examine existing practices, accountability mechanisms, and staff training. Yet, the current healthcare industry's readiness for the next emerging infectious disease event relies heavily on the healthcare provider's basic understanding and comfort in performing everyday infection prevention and control protocols. ANA appreciates the role of nurses in these processes, recognizes that the nursing practice intersects nearly all healthcare settings, and that nurses are key in transforming health and healthcare. At any given time, about 1 in every 25 patients has an infection related to their hospital care, which costs roughly $26 to $23 billion annually. Historically, infection prevention and control discussions and efforts have focused on infections in the hospital setting. Today, we would like to expand that conversation, use the opportunity to be more inclusive, and engage our colleagues in outpatient and ambulatory care settings in the conversation. Today's webinar is the 7th and final webinar within the NICE Network series, Empowering Nurses to Protect Themselves and Their Patients. Today's webinar will discuss infection prevention practices and challenges in women's health, obstetrics, and pediatrics, the importance of standard precautions, and practical solutions and ways to implement infection control in these specialty environments. At this time, I'll turn it over to Dr. Elizabeth Roshan with the Association of Women's Health, Obstetric, and Neonatal Nurses, AWHONN.
And good morning, everyone. And AWHONN is delighted to be part of this outstanding webinar series. And today we're going to take a focus on obstetric and women's health within infection prevention and control. So from a historical perspective to our discussion today, let's revisit Florence Nightingale's notes on hospitals. I am going to read, and feel free to read along with me. It will be seen at a glance that in every such case and in every such example, the infection is not inevitable, but simply the result of ignorance and carelessness. As soon as this practical view of the subject is admitted and acted upon, we shall cease to hear of hospital contagions. Now think about this for a moment. The year is 1863, and even then there is an understanding that infection can be prevented. So let's move forward now to my own entry into nursing school, and in that context discuss the evolution of contemporary infection prevention. So the year is 1987, and I have just graduated high school and began studies at a small diploma school of nursing in upstate New York. Now, it is interesting that some of you may have just gasped, either because you may have begun your nursing career much earlier, or you may not even have been born yet. In any case, this is an important time in the history of infection prevention. HIV and AIDS were first identified in 1981, and by 1987 there were tremendous efforts to evaluate and treat patients, and in 1988 there were even more dedicated efforts with the announcement of Ryan White, an adolescent who contracted HIV through a blood transfusion. Nurses during this time, particularly with the advent of universal precautions, were concerned that the human touch of nursing would potentially be disrupted by gloves and gowns. Infection prevention and control created a cultural shift that even today still aches for improvement. So I'd like to introduce you to AWHONN for a moment, and if you're not familiar with AWHONN, I'm going to introduce you. AWHONN is the Association of Women's Health, Obstetric, and Neonatal Nurses. These particular areas focus on clinical practice environments such as labor and delivery, surgical obstetric care, post-anesthesia care, postpartum care, neonatal and neonatal intensive care, and well women's health care. AWHONN supports the approximately 350,000 nurses across the United States who specialize in these nursing spaces. There exists a vast and complex combination of roles, and many nurses practice in more than one segment, while some nurses span their focus in all areas. For the sake of this conversation today, we are going to focus on obstetric and gynecological surgical care, and allow our NAPNAP colleagues to focus on infants and children. As a nurse, you play a dynamic and essential role in the chain of infection prevention and control. To explore the areas of infection prevention and control within the women's health setting, it is important to understand and appreciate the underpinnings of nursing strategies to mitigate infection and potential patient harm. Clearly, in the obstetric nursing space, exposure to blood, body fluids such as amniotic fluid, meconium, maternal feces are ever-present risks. We will discuss these risks in the coming minutes, as well as the patient risks that are associated with care. In both labor and delivery operating room locations, as well as gynecological surgical care, including hysterectomy and other gynecological invasive procedures, appreciating the iatrogenic risks to patients is absolutely essential. Let's focus in on some of those areas today. So first, it's important to refocus and return back to the basics. Standard precautions should be an ingrained part of our work every day. Standard precautions goes far beyond appropriate hand hygiene, masks, and gowns, but requires critical thinking and attention to detail. In obstetric and women's health, it is easy to assume that our patients are healthy patients and do not require the same level of analysis. This could not be further from the truth. It is essential to remember that standard precautions covers every patient, every time, and this does include healthy appearing patients. So let's review some of these standard precaution areas now, which includes appropriate hand hygiene, use of personal protective equipment if you expect a splash, a spill, or other exposure to blood and or body fluids, and to ensure that the environment is appropriately cleaned and disinfected. Let's review some scenarios in obstetrics that clearly have some opportunities for improvement in standard precautions. While we are reviewing these, we will also discuss the risks you will or you should see. So let's talk about labor and delivery. In a labor and delivery environment, potential exposure to blood and body fluids is a risk to providers, nurses, and other members of the healthcare team. Ensuring you are complying with your facility's infection prevention and control policies is absolutely essential to protect yourself and your patients. So, what should you see in these images that you do not see? In the top image, a provider is delivering a baby and exposing mucous membranes without the use of a face shield. In the bottom image, while it may seem very natural, is someone missing a pair of gloves? Again, identification of risk and risk exposure is essential in your role as a registered nurse, and holding others accountable to standard precautions is critical. Now, I didn't say it was easy, but it is essential. Does your facility utilize hydrotherapy or water birth for the women you care for? This adds an additional layer of complexity, particularly with disinfection and cleaning up facilities in between patients. According to the American College of Obstetricians and Gynecologists, the committee opinion in 2016 on water immersion during birth, facilities that plan to offer immersion during labor and delivery need to establish rigorous protocols for candidate selection, maintenance and cleaning of tubs and pools, infection control procedures, including standard precautions and personal protective equipment for healthcare personnel, monitoring of women and fetuses in appropriate intervals while immersed, and moving women from tubs if urgent maternal or fetal complications develop. In addition, AWHONS text Perinatal Nursing also highlights the importance of standardized infection control and prevention policies for hydrotherapy. But wait, hold on, let's back up for a minute. We need to go back to the beginning, or at least to the admission of the woman in labor. Infection prevention and control includes a thorough assessment and understanding of any potential infectious process for the woman or her newborn. For those organizations and facilities accredited by the Joint Commission, be sure to review the new standards for perinatal screening upon admission to labor and delivery effective July 1st, 2018. Some of your organizations may already be completing this admission lab profile included on this slide, including HIV, hepatitis B, Group B streptococcus, and syphilis. State laws may complicate these particular laboratory studies, so be sure to consult with your leadership team and infection prevention specialists to better understand your process. Postpartum considerations, particularly delayed bath, require special infection prevention policies and procedures to protect you as the nurse, as well as the other women and families you care for. Facilities have varied policies and procedures surrounding delayed birth, particularly as enhanced skin-to-skin and better thermoregulation and gluconeogenesis have been associated with delayed bath policies. Lotus birth, which in certain areas of the United States has become a requested birth choice, requires specific and clear infection prevention policies, particularly with handling the placenta and any associated fluid exposure. Again, what is missing in the bottom image? Adherence to standard precautions, including the utilization of gloves when handling a placenta or any other blood or body tissue, is absolutely critical. Your assessment and judgment of risk is essential in this environment, particularly in a situation where a natural birth has been requested by the patient. Having these infection prevention and standard precautions conversations prior to delivery is absolutely essential. So let's move to the operating room. The surgical and operative suites create their own unique infection prevention and control dynamic. Ensuring proper precautions requires a plethora of team members functioning independently, while at the same time in unison, to affect the positive outcome of a cesarean section birth. Within the operative suite exist risks to the operative team, including blood and or body fluid splash from the uterine incision, to accidental scalpel and sharps injury, to exposure to contaminated instruments after use. Again, structuring solid and sound infection prevention and control protocols and procedures are absolutely essential for the operative areas. A1 has the perioperative care for the pregnant woman evidence-based guideline that specifically reviews infection prevention in the obstetric operative areas, specifically in the areas of skin preparation and infection prevention in the operating room, including the roles of scrubbed and non-scrubbed staff. In addition, the Association of Perioperative Registered Nurses, or AORN, has a large library of infection prevention materials specifically designed for the operative environment. So let's take a quick station break and talk about teamwork. Communication is absolutely essential for any infection prevention and control program. The ability to communicate and hold one another professionally accountable for infection prevention is a role in which every member must participate. Each member is a link in the chain of infection reduction, and we cannot afford the weakest link in infection prevention and control. The women and newborns we care for are counting on us to do the right thing for them. So think about the math problem in this slide. While some of you may not have as large a unit as the one described here, this is simply to show the number of possible teams that can be created out of a unit staffing. What this means is that every member of the team has to do right by the patient and the team every time. So think about it. In your larger units, you could easily have 381 million different teams. That is certainly very important to consider when you're looking at the infection control policies of your organization. So let's move to GYN surgical care. We now move away from obstetrics to women's health, particularly gynecological surgery. This type of surgery has changed over the last decade from being a primarily open abdominal or laparoscopic approach to a more robotic approach. In addition, the vast majority of these women are cared for in outpatient settings, so the importance of infection prevention and education is paramount. There are specific infection prevention measures that are important whether in the operating room or caring for a patient postoperatively in the PACU, particularly from the standpoint of incision sites and monitoring for infection. In 2017, the Consensus Bundle on Prevention of Surgical Site Infections After Major Gynecologic Surgery was published and provided a framework within which to promote prevention of surgical site infection prevention. It is important to note that all surgical areas, including cesarean section, must be mindful of environmental hygiene. So let's talk about that. Environmental hygiene is an important facet of infection prevention and one that both the CDC and the Joint Commission follow very closely. It is tremendously important to understand that hand hygiene is but one of the many initiatives to reduce the iatrogenic infection risk within healthcare settings. Understanding your facility's policies on low-level disinfection, high-level disinfection, and sterilization practices is a patient safety imperative. This includes areas such as labor and delivery settings, labor and delivery operative areas, and gynecological surgical areas. Bioburden that is present on patient equipment must be mitigated and handled properly and per your facility policy. So let's talk a little bit about public reporting. So healthcare-associated infections, or HAIs, as we have been described earlier, have been tracked for over a decade by the CDC. Of note, the abdominal hysterectomy surgical site infection rate is tracked and reported yearly. Over the years 2008 to 2014, there has been a 17% decrease in surgical site infections specifically for hysterectomy. While this is certainly good news, it is important to understand that the CMS website hospitalcompare.com utilizes this surgical site information and publicly reports this data on its website. Consumers are able to compare hospitals against one another and determine their choice for care based upon a number of items, including patient experience and complications, of which surgical site infection is one of them. I encourage you to review your hospital's publicly reported data and think about this. Would you go to your hospital based on your data, or would you go to a competitor? You might be surprised. Every year, approximately 385,000 healthcare workers are exposed to a needle stick injury. The Centers for Disease Control estimates that 5.6 million healthcare workers are at risk for blood-borne pathogen exposure. However, needle stick injuries are not the only exposure healthcare workers are exposed to. Splashes of blood or body fluids onto mucous membranes or skin that is not intact can be just as harmful. In the event of an exposure, it is critical to liberally rinse with soap and water and contact your supervisor or covering leader immediately, and to seek treatment per your facility's guidelines. It is essential to know your facility resources before you need them. For example, if you work night shift or on the weekend, where do you go for an exposure, particularly if your employee health services are not open? Exposure control plans are essential to have and have them updated regularly. And now we're going to go on to Beth Luthi from the National Association of Pediatric Nurse Practitioners. Beth, take it away.
Hello, my name is Beth Luthi. I'm a family nurse practitioner and a proud member of the National Association of Pediatric Nurse Practitioners. For this webinar, I'd like to focus on the importance of what we as nurses can do to protect ourselves and our patients from vaccine-preventable diseases, specifically measles. There are three main objectives of this presentation. So objective number one is that at the conclusion of the presentation, you should be able to understand the role of standard precautions in minimizing exposure to infectious diseases, especially measles. Objective number two is that the learner will be familiar with strategies for early risk recognition of infectious diseases, specifically measles. And objective three is that the learner will be able to recognize the importance of vaccinations in preventing infectious diseases in healthcare workers and patients. There are many different types of vaccine-preventable diseases we could discuss, but today we're going to focus on measles. Measles is one of the most contagious infectious diseases. In fact, 9 out of 10 unvaccinated people who are exposed to a person with measles will develop the measles infection themselves. The virus can remain infectious in the air up to 2 hours even after the infected person has left the area. Those who are infected are contagious 4 days before the rash shows up. Measles is well known for its maculopapular rash, but keep in mind that the rash does not appear until about 4 days after the appearance of other symptoms. Symptoms that often accompany measles include high fever, in some cases as high as 105 degrees Fahrenheit, coryza, which is runny nose, cough, conjunctivitis, watery eyes, sore throat, and Koplik spots or white lesions in the mouth and on the throat. The first measles vaccine was licensed in 1963. Before the measles vaccine, we had 3 to 4 million cases of measles every single year in the United States. So the U.S. set out to eliminate measles with an aggressive vaccination campaign in 1978. By 1980, the number of measles cases in the U.S. had dropped by 80%. In 1989, a second dose of MMR vaccine was added to the vaccine schedule. Measles was declared eliminated from the United States just 18 years ago in the year 2000. Now, that doesn't mean that there are no cases of measles in the United States. It just means that there was an absence of continuous disease transmission for greater than 12 months. We still have measles outbreaks every year in the United States. Most of these cases are imported from other countries around the world and are in people who are unvaccinated. While measles outbreaks occur every year in the United States, the number of cases fluctuate. For example, in the United States, there were 118 cases of measles that spread across 15 states in the year 2017. In 2014, there were a record number of measles cases in the U.S., 667 cases to be exact, which is the highest number of cases since measles was deemed eliminated from the U.S. in 2000. Standard precautions are used for all patient care. Appropriate precautions are based on the risk of disease transmission as well as solid common sense practices and the use of personal protective equipment. All of the personal protective equipment listed at the top of this slide prevent contact with infectious infectious agents and body fluid that might contain an infectious agent. However, keep in mind that measles is an airborne infection and therefore requires airborne precautions. If infection with measles is a possibility, the healthcare worker and the patient should take extra airborne precautions. The first thing is to assess the risk associated with measles. The single best way to prevent measles infection is to be vaccinated with the MMR vaccine. Those who have been vaccinated with 2 doses of MMR vaccine have the best chance of being immune to the measles virus. Because measles infection was so common before the introduction of the MMR vaccine, people who were born before 1957 are assumed to have immunity to measles. Risk assessment then would include assessing which healthcare workers and patients have completed the 2-dose MMR vaccine series or who have documented immunity against the measles virus. If the healthcare worker has had their 2-dose MMR series or has established immunity, their risk for contracting measles is mitigated. Common sense practices regarding measles would include limiting airborne exposure to the person infected with measles. Access to the infected person with measles should be restricted. That means the fewest number of healthcare workers possible should enter the room of a person suspected as having measles. Also, the patient suspected of having measles should enter a separate entrance to the clinic if possible and sit in an exam room with the door closed. Because measles is an airborne infection, special airborne precautions should be followed when interacting with the patient who might have measles. According to the CDC, that means that healthcare workers should always use an N95 respirator when entering the room of a potentially infected patient. This guideline should be adhered to regardless of the healthcare worker's MMR vaccination status. That means that even healthcare workers who have received the 2-dose MMR series should still wear an N95 respirator when in contact with patients who may have measles, because no vaccine is 100% effective. Therefore, to provide consistency in the practice setting, everyone who enters the patient's room should be wearing an N95 respirator. The person suspected of having measles should be placed in a single patient airborne infection isolation room known as an AIR room. That would be AIIR, or a negative pressure room. If this type of room isn't available, the person should wear a face mask even when in the exam room. Jane Seward from the CDC coined the phrase, "Suspect measles? Act fast." If you suspect a patient has measles, act fast by quickly isolating the patient and then contacting the local health department. Specimens should be collected from the patient. The most common testing for measles includes the measles-specific IgM antibody and the measles RNA RT-PCR test. A throat or nasopharyngeal swab should also be obtained for testing. In addition, you can also collect urine and respiratory samples to test for measles. Typically, it takes about 1 or 2 days to get the results back. And until results are available, patients suspected of having measles should be isolated at home until the results are reported. Patients with confirmed cases of measles should continue isolation until 4 days after the beginning of the rash. Anytime the patient with measles interfaces with the healthcare setting, the patient should wear a mask following airborne precautions. Aside from the patient who has the measles, consideration should also be given to everyone with whom that patient has had contact. The most appropriate intervention for people exposed to measles depends upon which category they fit in. The best way to determine which type of post-exposure prophylaxis is best after measles exposure is to consider the person's vaccination status. If they've been vaccinated with the 2-dose MMR series or are born before 1957, immunity to measles is assumed, and as a result, no further action is required. If the patient has no proof of their MMR vaccination and no proof of antibodies to measles, prophylactic treatment is then dependent upon 3 different factors: their immune status, their pregnancy status, and their age. If the patient has a competent immune system, is not pregnant, and at least 6 months of age, then they should receive post-exposure prophylaxis for measles with the MMR vaccination. This vaccination needs to happen within 72 hours of the exposure. Post-exposure prophylaxis is also available for patients who are immunocompromised, pregnant, or from 6 to 11 months of age, although instead of vaccination, these patients receive immunoglobulin within 6 days of the exposure to the measles virus. For immunocompromised or pregnant patients, post-exposure prophylaxis includes intravenous immunoglobulin. Infants from 6 to 11 months of age receive intramuscular immunoglobulin. Because my primary practice setting is in the outpatient clinic, I'll share some ideas on how we as nurses can prevent the spread of measles in an outpatient clinic setting. Having an isolation room in the clinic is a good idea, but most clinics do not have access to a negative pressure isolation room. If the clinic has an isolation room, that is great. If not, consider using the exam room that is the farthest away from patient traffic, or that is closest to the alternate entrance that the patient was brought in. This action quickly gets the patient into an exam room while simultaneously bypassing the waiting room. It is imperative that outpatient clinics require healthcare worker vaccinations as part of employment. Have vaccination policies in place with consequences for non-adherence, and update healthcare worker vaccination records every single year. All healthcare workers should be vaccinated against measles and all other vaccine-preventable diseases, or have proof of measles immunity. If for some reason the healthcare worker is not vaccinated against measles and cannot prove immunity, and the clinic has hired them anyway, the worker should still be encouraged to receive the 2 MMR vaccinations. It's also a good idea to keep the phone number of the local health department handy, just in case a reportable disease is discovered. And it's a good idea to restrict patient contact with other individuals as much as possible. And we'll talk more about this in just a couple of slides. I wanted to share a story with you. On January 5th, 2015, a very busy pediatric clinic in Utah, which just happens to be where I am from, was open for after-hours appointments. 2 children came into the clinic with their parent, checked in at the registration desk, and took a seat in the waiting room. Because the 2 children looked so ill, the receptionist approached one of the healthcare providers who had the children brought to an exam room. The healthcare provider was very experienced, and the moment he entered the exam room and saw the 2 children with noticeable rashes, he knew the children had measles. After gathering a patient history, he discovered the children had recently returned home from a family vacation to Disneyland. He immediately contacted the local health department and ran confirmatory tests. The children were discharged to home and were told to remain quarantined until receiving further instruction from the local health department. Now luckily, the healthcare provider in the Utah clinic quickly recognized that the children had measles. Since that time, however, the clinic has changed policy to restrict contact with a potentially infected individual. Now, any child with fever and rash are brought through the back door and immediately placed in an exam room. Early risk recognition of measles is essential in order to minimize exposure to the virus. The screening process should begin as early as possible with those making appointments or those doing triage. When making an appointment for a sick patient, the scheduler should always ask why the patient needs to be seen. If the patient reports fever or rash, it is important to ask if the patient also has the other symptom. For example, if a parent calls to make a sick appointment for their child who has a fever, the scheduler should ask a follow-up question to see if the child also has a rash. Any patient with both fever and rash should be suspected of measles, especially if the patient is unvaccinated, if the patient has a known exposure to measles, or if the patient has recently traveled internationally. These patients should bypass the waiting room, entering through a back door or an alternate entrance while wearing a mask. They should go directly to an exam room that is away from high traffic areas. The door to the exam room should always be kept shut. Be sure to contact the local health department. Rather than taking the child to a common area within the clinic to have their labs drawn, or sending the patient to a different lab to have their labs drawn, they should instead have labs drawn right in their room. The patient should be examined and discharged as quickly as possible, and the room should be routinely disinfected. If the room is not a negative pressure isolation room, it is best to avoid using this room for at least an hour. If that is not possible, only patients who have had both doses of MMR vaccine should use the room exposed to measles. Nurses working in triage or receptionists at the front counter should also be aware of the risk for measles when patients have fever and rash, and should assess patients to find out if they have both symptoms, and if so, these key individuals should take immediate action when recognizing the risk for a measles infection. According to the CDC, healthcare workers are at a unique risk for being exposed to serious and sometimes deadly infections, some of which can be prevented through vaccinations. Because healthcare workers have this unique risk for exposure to communicable diseases, that means that their patients and their families also have this risk. The CDC recommends that healthcare workers receive each of the vaccinations listed on this slide. Keep in mind that the single best way to prevent measles infection in the healthcare workers is for them to be vaccinated with the MMR vaccine. Now that we've reviewed the recommendations of the CDC for healthcare workers, let's take a look at how well healthcare workers are vaccinated with MMR in the United States. There are a few studies reporting healthcare worker vaccination rates for measles, mumps, and rubella. Confirmation studies of immunity in healthcare workers shows that these workers have between 87 and 97% confirmed antibodies against measles, mumps, and rubella. Rubella, by the way, is the highest at 97%. And just FYI, Healthy People 2020 only has 2 vaccination goals for healthcare workers, which include 3 doses of hepatitis B and a seasonal influenza. Measles has not yet been included as one of the Healthy People vaccination goals for healthcare workers. In the outpatient clinical setting, and where I work as a nurse practitioner, there is little to no information about vaccination policies, although my research group has collected some data in Utah. The vaccinations listed in the box outline which vaccinations are included as part of the clinic vaccination policy. My research team has collected data from pediatric, family practice, and oncology clinic settings. Notice the influenza, hepatitis B, and Tdap vaccines are the ones most commonly included in vaccination policies in the outpatient clinic setting. If we were to compare the vaccination rates of healthcare workers in the United States with those in Utah outpatient clinics, we would find that vaccination rates for Tdap and influenza are comparable. But for all other vaccines, including measles, inpatient facilities have higher vaccination rates of their healthcare workers than healthcare workers employed in the outpatient setting. As a quick reminder, MMR vaccination rates in healthcare workers in inpatient institutions have vaccination rates of 87 to 97%. In Utah outpatient clinics, MMR vaccination status, which by the way is the 4th row down on the table, was only required and tracked in 42.6% of pediatric clinics, 32% of family practice clinics, and 41.7% of oncology clinics. That means that those of us working in the outpatient clinic setting have quite a bit of work to do to improve healthcare vaccination rates against measles. There are a few documented barriers to vaccinating healthcare workers. The most common barriers include lack of access to the vaccine while working. The belief that vaccines are unnecessary is another common barrier to healthcare worker vaccinations, as well as the cost of vaccines and high staff turnover, meaning that occupational health or the clinic managers do not have the ability to effectively track vaccinations because there is too much turnover in staff. For those of you who work, like me, in outpatient clinic settings, the most prominent barriers to vaccinating healthcare workers, and by the way, this is from the office manager point of view, is a lack of time and resources and wanting to respect employee freedom to make their own decisions regarding recommended vaccinations. So where do we go from here? For everyone listening to this call and to all organizations who are part of the NICE network, let me just reiterate that every nurse and every healthcare worker has a responsibility to ensure patient safety. Every nurse is a patient advocate, and we should all be change agents when needed. You should be knowledgeable regarding standard precautions, risk recognition for measles, and the importance of vaccination for healthcare workers. If your organization does not yet have a healthcare worker vaccination policy, please advocate for one. We know that vaccination rates among healthcare workers are higher when the institution for whom they work has a clear vaccine policy and a clear message from the highest administrators. If your nursing organization does not yet have a position statement on healthcare workers and vaccines, I would encourage you to start that process and follow through. It is important to send a unified and positive message regarding patient and healthcare worker vaccination rates, not just for measles, but for all vaccines that are recommended by the CDC. Let me end by saying how proud I am to be a part of such a noble profession. I support the NICE network statement of, quote, empowering nurses to protect themselves and their patients by providing real-time infection prevention and control training to United States nurses, close quote. Immunizations are an important tool to protect ourselves and our patients from infection. Thank you to the NICE network for letting me speak on a topic that is so near and dear to my heart. And a special thank you to the National Association of Pediatric Nurse Practitioners, of which I am a proud member. I thank each of you for your time.
Thank you, Dr. Luthi. Thank you to the speakers for your time and expertise today. This brings us to our Q&A session. And as a reminder to participants, please submit your questions via the chat window located on the lower left-hand side of the webinar screen. Joining us today for our Q&A session is Dr. Michael Bell, Deputy Director of the Division of Healthcare Quality Promotion. Our first question is for Dr. Roshan. We have had several mothers come in requesting lotus births, but our infection prevention practices do not allow this. However, we are also told to keep our patient satisfaction scores up, and we are now denying them something in their birth plan. What strategies can you use to inform mothers of your policies without making them disappointed? Dr. Roshan?
Wow, thank you. Yes, wow, thank you. And that was a great question. For those on the call that may not know what a lotus birth is, a lotus birth is a relatively new phenomenon that's occurring with more natural birth, in which the placenta remains attached to the umbilical cord to the baby, and then basically as the umbilical cord naturally falls off, as does the placenta. So in essence, you have not only the baby who you are now worried about from an infection control standpoint, you also have the placenta, which typically rests beside the baby, which could be in a basket, it could be in a bowl. There's a number of ways to do this. So certainly many organizations that we have heard have really struggled with this, and from an infection prevention, infection control standpoint, have decided that they would not support lotus birth within their facilities. However, that being said, this is certainly a conversation that requires it's a multidisciplinary approach that requires physician input, nurse input, consumer input, infection prevention input. So I would say that there's not a singular answer to this. I think it's more of a what works for the facility, what works for your patients, and what works for your infection prevention policies that are safe not only for your nurses and for the providers, but also for the other patients that you are coming into contact with. So I know that's not an outstanding answer, but I think it's probably the best answer that we have. And it's also to ensure that patients or women who are coming in to give birth also understand your policies and procedures. And having those conversations before a woman comes to the hospital to give birth is equally as important. If you don't have those conversations before, it's really hard to have them afterwards. So I would encourage conversations in the physician's offices or the provider's offices, nurse practitioners' offices, and midwives' offices before the woman comes in to deliver.
Thank you, Dr. Roshan. Our next question is for Dr. Luthi. There are other healthcare workers in my organization who refuse to receive vaccinations, and there is no vaccination policy. How can I convince my organization to institute and enforce vaccination policies?
And that is the $1 million question. So there are a couple of different reasons that that I think can be used to convince the organization. So one of which is there are ethical reasons for vaccinations. And keep in mind that what we know is that public trust is damaged when healthcare workers recommend vaccines for patients, but they avoid vaccines themselves. And then also keep in mind that vaccines are consistent with our professional obligations to protect patient safety. And healthcare institutions have really an obligation to reduce the risk of infection to patients. And not everyone speaks in ethical terms, right? So there are economic benefits. So you can mention those economic benefits. Vaccines reduce absenteeism among employees for employee illness, but if the employee and the family members are also vaccinated, then you reduce absenteeism for employees who would be home because a family member is ill. And then I think everybody who's in authority at whatever the organization is, they all need to be in agreement and they all need to send a clear message regarding vaccines. It needs to come straight from the top, and it needs to be very simple and very straightforward on what the expectations are.
And a follow-up to that question, do you think that employee vaccine mandates are effective?
So that's a great question, and I know there's been some debate back and forth. I think it's just taken some time to figure out. We had to wait for enough of the institutions to institute something to see, but I know that vaccination mandates have been instituted already by over 400 healthcare institutions in the United States. And when an institution has a vaccine mandate for healthcare workers, vaccination rates increase eightfold. So very, very high. And then a couple of specific examples. So Virginia Mason Medical Center in Seattle, Washington instituted mandatory influenza vaccination for healthcare workers. And they had a 98% vaccination rate following release of the mandate. And then also Children's Hospital of Philadelphia instituted a mandatory vaccination policy for their healthcare workers, and their vaccination rates climbed to 99.9% in just 1 year. And that immunization rate for CHOP, or Children's Hospital of Philadelphia, they'd been struggling specifically with having their healthcare workers vaccinated for influenza vaccine, and it was always their vaccination rate was always hanging around 60 to maybe 70%, which is what it usually is if there's no mandate in place. But to go from 60 or 70% to almost 100% in 1 year is pretty amazing, and evidence that mandatory vaccination policies do actually work.
Thank you, Dr. Luthi. Our next question is for Dr. Roshan. Given the risk of postpartum group A strep infection and possible healthcare provider carriage, does A1 have formal guidelines or recommendations for recommending mask and eye PPE when suturing a perineal tear or a episiotomy?
Yeah, this is another really great question, and I appreciate the audience's interest in this. So from an A1, from a recommendation perspective, the recommendations are first to ensure that that a nurse is following their specific facility's infection control and prevention plan. That, while certainly A1 has their professional guidelines, it's also very essential that nurses are following their guidelines and recommendations from their own hospital infection control standpoint, from a local or state standpoint as well. A1 certainly does support the judicious and effective use of infection prevention and standard precaution elements, including gowns, gloves, masks, face shields for certain procedures that require it, and if nurses or providers are expecting to be exposed to particular elements or particular elements, for example, blood during a repair or a procedure. So certainly understanding your facilities, policies, and procedures along with your local and regulatory bodies is really essential. So certainly A1 supports the facilities utilization of infection control policies and procedures, and wants the nurses who are caring for women and newborns to ensure that they're following the procedures that are dictated and regulated by their institutions, their cities, and their states.
Thank you, Dr. Roshan. And another question for you. The family birthplace would like to make natural birth less of a medical procedure. They feel that wearing PPE like a mask with visor leads to a less than family-centered care delivery. Do you have any views on this approach? Natural birth is certainly something that women support. That A1 supports a woman's right and desire for the birth that they want to be able to experience. However, as we are ensuring that the woman has the opportunity to have the birth that is important to them, it's also essential that we are able to protect healthcare workers and their health as well as their well-being during a delivery. So I do think that certainly there are conversations that can and should be had during a woman's pregnancy, as well as at the time that they arrive wherever that birth facility may be, whether it be a freestanding birth facility or a hospital birth facility or even in the home with a midwife. It's really important that we have these conversations with women to ensure that not only are we affording them the birth that they want for themselves and their families, but that we're also protecting the healthcare providers, particularly the nurses, midwives, and others who are caring for these patients. So I think it's a delicate line. I think that there are certainly some individuals who choose not to use
protective equipment. And I think that that is a risk that they take, and that a risk that they certainly that they do on their own. But once again, I would say following your facility's rules, regulations, and guidelines is absolutely essential to providing not only a healthy, happy birth for a woman and her family, but also ensuring the best possible safety and security for the teams that are caring for her.
And this is Mike. I'll just chime in and say that I think that we're seeing that when there's a recognized threat to healthcare staff, suddenly the conversation changes. For example, with things like Zika virus or Ebola, and I think that's an indicator that people, when they're thinking about the risk of transmission during a procedure like this, they are willing to use protective equipment appropriately. I think what you just heard, though, about the importance of an early conversation so that moms aren't caught unawares or surprised by protective equipment is a hugely important factor. And I'll throw in the additional thought that protective equipment does protect the wearer, but it also reduces transmission from patient to patient. And so when labor and delivery is occurring in a healthcare setting and other patients and moms are at risk, then the cross-transmission piece becomes important as well. So it's not just a simple, make it feel homier question. I think these other elements of occupational safety and cross-transmission do need to be included in conversations with all moms and prospective patients.
Thank you, Dr. Bell, and thank you to our speakers. This actually concludes our Q&A session. Thank you to the participants also for your questions today. Before we go, just wanted to mention a few items about continuing education. To receive continuing education for today's webinar, please visit TCEO before June 15, 2018. You must complete the continuing education post-test and evaluation, and you must complete and pass the post-test activity at 66% to receive continuing education. Please follow the detailed instructions that will appear on the post-meeting webpage right after you close out the webinar. The course access code is CDCANA515. A follow-up email will also be sent after the webinar with the slides and with detailed instructions on how to obtain the continuing education credits. With that, I'd like to thank our speakers as well as all of you for taking the time to join us today and for your commitment to keeping your patients safe. Thank you.